I think I'm recording. um, I hope I am.
Yes,
You are.
yes, yes,
You are.
it's on the screen, yes.
Okay, because I like I said, I don't really know what I'm doing, so I try, but I do know for community health, one of the chapters is community mental health. So hopefully, even if you're not in Dr. D's section, hopefully this will be useful for a future quiz or the midterm. I don't know what the K is doing, but I'm assuming the chapters are the same. But I don't know. I can't speak for everyone. But okay, when you're all ready, just let me know, and then we can kind of go over it together. And like I said, if you want my typed version, I don't mind sending it. I really don't. Just let me know. See. Okay. So it seems like everyone's settled now. So the first thing I see is basically like, what is schizophrenia? You can kind of start off there.
Are these your personal notes, Alicia?
Yes.
Okay, oh, I was looking at the one that Dr. D, you typed over it, and again, thank you so much for doing that.
Oh
And I
yeah,
thought
I
that was
like
the one that you were
retyped
going over.
everything. Yeah, I retyped
Thank
everything
you
that
so
she
much. You're
did
a
just in a
lifesaver.
type. Yeah, I
Thank
redid
you.
it. It's the same thing. I just kind of put it out like it's all there. It's just not in doesn't look like that.
Yeah, thank you. All right. Proceed. Sorry.
No, you're good. So yeah, this is the same thing. I just need to have it typed. It's a very mental thing for me. I love typed things. But what I remember is that like with schizophrenia that it does affect a lot of the young adolescent population, if I'm not mistaken, and that it affects the dopamine receptors according to her notes. And we have positive and negative symptoms. So does anybody remember what the positive symptoms are? Or any positive symptoms? Okay, so it's okay. So I was going through it and I was trying to remind myself, well, I remember that the negative symptoms were like all of the A's. So some of the ones were anhedonia, which is not getting pleasure in pleasurable activities, which is what we also see in depression. Anergia, which is no energy. I had to remind myself of a lot of these, and this is not from really memory. Avolition, which is the impairment of goal-directed activities. Alogia, which is limited speech. Autistic thinking, which means they live in a fantasy world, and they also have neologisms. Does anybody remember what that word means, neologisms?
Making up a word.
Yes. Random made-up words. They don't even make sense. But in autistic thinking, the reason I remember Dr. D said that a lot of schizophrenic patients do that is because they want to have that disconnect between us and the real world. So what they do that by making up words to kind of separate us from communicating. We have deteriorations in appearance, apathy or no interest or desire in things, ambivalence, which is that idea of where they want to live, but the situation that they're going through is making them not want to live, and they feel like they can't get through it, so they want to live, but they feel like they can't with this current situation. Affect, which is inappropriate, flat, or blunted. So what's an example of like an inappropriate effect that a patient might give who has schizophrenia?
Maybe like if the situation is sad, they're reacting like inappropriately, like maybe they're laughing.
Yeah, I was thinking like laughing at a funeral would be a very inappropriate affect that they could potentially do. Anybody else have anything to share with that?
Running in the street naked?
Yeah. That would definitely be inappropriate. I could definitely, though, see that more for a manic patient than someone with schizophrenia.
Okay.
Because they I remember they have like a increased sexual drive, and they have like these grandeur thinking, and they're very like into themselves. So I could definitely see that with them. Anything else anyone wants to add with affect? What about like flat affect? What example would that be? I think of things like no effect at all, right? Like if you're supposed to laugh, they're not laughing. If you're happy, they're not happy. They have no reactions to anything.
Like no emotions at all?
Yeah, like they're just kind of like there. Like they're not interacting. They have no sort of reactions when they're supposed to have reactions. And blunted is like a semi-reaction. So maybe they'll kind of smirk at something. Maybe they'll semi-smile. It's kind of like a halfway sort of appearance. But regardless, anything with an A are the negative symptoms. Always A words. So even if we didn't necessarily remember what they are, if she mentioned what are some like negative effects or negative symptoms, we know something with an A. So anhedonia, anergia, avolition, alogia, things like that. And like I said, you can either write these down or I could send it to you at the end. It doesn't matter. It has all this in there. And positive symptoms are like everything else. So there's delusions. Does anybody remember any delusions, or so there was different types?
I know there was one that was somatic delusions, and it was like anything that has to do with like the body or like physically.
Yes. They would manifest symptoms that they might hear, or they might think that they have something like, oh, you have HIV, and they're like, you put this in my cup, so now I have it. What other?
Somatic and grandeur, whatever I can pronounce that. Delusion of grandeur.
Yes, and we also see that one in mania, which is like they think they're the best at everything. Like I'm the king of the world. They definitely believe that. What else? Is there any other delusions?
There's one, I forgot what they're called, but it's like when you believe in somebody in love with you, or like somebody likes you a lot.
You like Dr. D and
Theater, yeah, it's the only way I remember that.
Yep, that's called erotomaniac, and they believe that they're in love with someone who has higher status than them. What else? What about, is there paranoid delusions?
Yeah, I know that's definitely one as well.
So they're like withdrawn, they're like suspicious of everything. There's also the referential thinking. Does anybody remember what that one is?
Is that the one that they think that somebody's out to get them?
That would be more like paranoid.
Right, paranoid.
Referential thinking is more like the electronics and the things around them are talking to them. Like the TV is speaking to them, or the radio is telling them something. Other ones are like thought withdrawal. They believe that someone's pulling thoughts from their head, or thought insertion. They believe someone's putting thoughts into their head, or thought broadcasting, where they believe other people are hearing their thoughts. And there's jealous delusions, like they get really jealous easily, so I guess if they think their partner is like cheating on them or something like that. And other ones are neologisms, as we said, are making up words. Does anybody remember what word salad is?
When they like mix up words.
Yeah, so just like a bunch of random words, like bottle.
Random words that makes no sense.
Yeah, it's even hard for me to do that because, like, we don't think in that pattern or that set of mindset. So I'm trying to think, like, what would be random words? Like cap and paint, I don't know, bed, then none of it makes sense. They just say a bunch of random words. Clang association, which is rhyming, so they rhyme a lot. I remember loose association, which was a hard one. Does anybody remember what that one was? Or like an example of that one?
No, I don't remember that one.
That's the one where it's like, oh, you're the light of my life. And then they talk about like, oh, but God is there for me and God is my world. And then it's like, circles are in the air. Like they kind of say sentences, like the sentences kind of make sense, but they're not connected logically. Like there might be something that's similar in that sentence that kind of makes sense, but each sentence is kind of different. So there's like, so yeah, it's a weird one. I remember she gave us one like, oh, you're the light of my world, and then God is my light, and light is a match. Like they don't really relate. There's like something that you can kind of see like a pattern, but it really doesn't make sense. They also have like religiosity, which is a positive symptom. They're like obsessed with religion. They could have flight of ideas, which are just random sentences that are not together. So like random flight of, I guess the difference between loose associations and flight of ideas is like flight of ideas are actually just really random sentences. The loose associations might have some sort of connection to them, like with the idea of light. Even though all those light sentences didn't make sense, they all had to do with this idea of light. Whereas with flight of ideas, they might be talking about, I'm a cop, and then they say, I fly planes. Like, that they don't relate at all. They're just two random sentences that are put together. Then they have, preservation, where they repeat words or thoughts. Circumstantiality, which is where they have really detailed responses. Like, you know when someone talks, and then it just doesn't make sense. Like there's no point of the conversation. It's just like, well, where are you going with this? That's what circumstantiality is. Like they just kind of keep talking and you don't know where the conversation is leading to. They can go off on tangents, where that basically means that they just go from one idea and shift to another. They have concrete thinking, where it means the literal meaning. So if I say, oh, that's a nice name, or like, what's your name? And you're going to be like, name. Like, they're going to just say something so concrete to what you're actually saying. Like, oh, I would love that name. And they're like, well, it's my name. Like, you're not actually saying I want their name. They're just going to think that you actually mean that. They also have magical thinking, where they believe that they can control the situation or others with their actions. And we also talked about paranoia, which they have a risk for violence. And do you guys remember echolalia or ecopraxia?
Yeah.
Yeah, those are also signs. So echolalia is when they repeat words, and ecopraxia is when they repeat movements. So they do that too. And they can have hallucinations in positive. So if they have a hallucination, what's something that we want to assess for?
I don't know if this is right, but I think she said if they're hearing voices.
So we want to have an assessment for, what do we call those?
Command hallucinations?
Yes, because remember, hallucinations are sensory. So like vision, hearing, taste, smell. But hearing, if they're hearing things, someone's telling them, a voice is telling them, hey, I want you to kill that person. We need to know. So we need to ask them, are you having hallucinations, or are you hearing anything? You know, we want to ask them about that. Like, are you having somebody talk to you? And if they say yes, we ask them, well, what are they telling you to do? Are they telling you to do anything? So, because we want to make sure they're not telling them to hurt somebody. But Just some other things that I also added in there were like with paranoid, because she also put like nursing interventions. I remembered like what sorts of things would you want to do if someone has paranoid schizophrenia?
Build trust.
Mm-hmm. Yeah. Right. Would you? Hmm?
I know she said, like, if you're talking to someone, don't talk to them next to them because they're going to think that you're talking about them. Because they're just annoyed.
Oh yes, I remember that. Also. Mm-hmm.
Would you want to whisper with these patients?
No.
And you probably would want to explain everything to them, right?
Yeah.
Because if you're paranoid, right, you're going to be nervous that somebody's out to get you, someone's out to harm you. So you want to explain everything to them, and you don't want to touch them. You want to give them their personal space. You don't really want to approach them alone, especially because they have a high risk for violence. Whereas if the client is maybe socially withdrawn, we want to approach them more frequently and, at their own pace, but slow, frequent interactions because, they might not talk to anybody and they might not express their needs. So we want to be more with them, and assigning the same nurse would be good too, because if they're socially withdrawn, having the same nurse would make them more comfortable. Okay. So now I know what the next thing you said. We have first generation antipsychotics. So I took some time to actually try to find some of the generic and brand name things that she said to do. So we have the typical antipsychotics that cause EPS, or the extrapyramidal symptoms. And which symptoms are reversible and which one is irreversible? 3 are reversible and 1 of them is irreversible.
I know the one that's irreversible is, oh my god, I just forgot. I literally just had it.
Tardive dyskinesia.
Is that the one with the eyes?
Yeah, that's the facial, lip smacking, that thing.
Yeah, I think that one.
That one is irreversible, so sadly we can't give anything for it. But what are the reversible ones?
So the reversible ones would be Parkinson's, akathisia, and dystonia, and then the tardive dyskinesia is the irreversible.
Yes. So akathisia is the restlessness. Dystonia is when the muscles contract involuntarily. And Parkinsonism is like Parkinson's disease, so we have that shuffling gait. And if they have that, what we want to give is the anti-Parkinson agents, and cogentin, Artin, and Benadryl. I actually took the time to find the generic and brand name. So the generic name for cogentin, the brand name. No, that's generic. Sorry. The generic name for cogentin is benzotropine. And then the generic name for Artane is trihexabenadryl. And then diphenhydramine is the generic name for Benadryl. So those are what we give for the reversible symptoms. And we get those from our first generation typical antipsychotics. What are examples of the first generation typical antipsychotics? Well, Haldol is one, and the generic name is haloperidol. We also have Prolixin, and its generic name is fluphenazine. And then we also have chlorpromazine, and the brand name is Thorazine. And she said with Thorazine, the thing that we need to watch out for is photosensitivity. So that's with the first generation antipsychotics and how we use the anti-Parkinsonian agents. And then we have second generation antipsychotics. I didn't get to search up more. I didn't get to search up the generic names and things like that. But I know that these are the atypical antipsychotics that cause metabolic syndrome. So what are the symptoms of metabolic syndrome?
Increasing sugar, increasing cholesterol, high blood pressure, gaining weight.
Yeah. So increased weight, increased blood pressure, increased blood sugar, and cholesterol levels. So we really want to monitor, lab values, vital signs, things like that. So interventions would be like fasting blood sugar before giving meds, monitoring blood pressure, monitoring lab values, things like that. And yeah, an example is risperidol. I didn't get, there's more. I just didn't get them all. I didn't get to find all of them yet. But we were also talking about in class about depot medications, where they are long-term, the IM injections. The way I understood this, unless someone else understood it differently, is that the depot medications, they're long-acting, and they're in these intramuscular injections, and they would be called like Prolixin depot or like Haldol depot. And basically when you give it, it can cause the risk of neuroleptic malignant syndrome. I don't know if anybody else has anything different for that. But something that we know with neuroleptic malignant syndrome is that it causes a really high fever, like 102 to 104. It causes lead pipe rigidity, altered mental status, altering either high or low blood pressure, and tachycardia. But the fever and like the lead pipe rigidity are like very important ones. And yeah, obviously we know that you can only give an antipsychotic medication if they're experiencing psychosis. And what does it mean to have psychosis? It means that you have hallucinations or delusions, right? Because we wouldn't give this to someone who has anxiety. We wouldn't give this to somebody who has depression because it wouldn't make sense. So we give these for people who have hallucinations or delusions, but potential consequences of these actions could be EPS, like in Haldol, or it can cause metabolic syndrome if you're taking drugs like risperidol. And yeah, any questions with that? So far, so good. Okay, so the next one is the mood disorders like depression, mania, and bipolar disorder. So when we think of depression, what should we worry about?
Suicide.
And when we think of mania, what should we worry about? Okay. And what is bipolar disorder? Like, what is it? Huh?
Combination of people who are depressed and people patients who have mania.
They interchange. They could be depressed and they could have mania. They have both.
That's why they switch.
Yes, the switch.
Exactly. And what are like symptoms of depression?
Sad, low self-esteem.
Yeah, definitely low self-esteem.
What about when you're depressed? Do you really have mood to like do anything or get up out of bed?
Don't want to eat.
Not motivated.
Right? So with these patients, you should probably monitor their diet and nutritional status with intakes and outputs because they're probably not going to want to eat much. Or the opposite. I know sometimes when I'm stressed, I overeat. And we also said, what was the big thing that we really wanted to worry about when someone has depression?
Suicide.
Yes. So when we're having these patients, our priority is making sure that we do a suicide assessment on them. Or if we hear anything that sounds like they might be considering suicide, we need to notice that, right? Like a change in appearance all of a sudden could be a sign that they're feeling suicidal, or if they start getting their finances together, or they say things like, oh, I don't really want to live anymore. That's when we really gotta do our suicide assessment.
And also, if like when we do our assessment, we see like, okay, they contemplating on suicide. So we will ask them, do you have any plans of killing yourself? And if they do, you find out like how are they planning on executing it.
Yes. It's like, are you suicidal? What is your plan? How do they have the means? And then we want to put them on that one-to-one and do those room checks and, make sure they're never really alone and all of that. What about mania? If depressed is low life energy, what is mania or being in a manic episode like?
Always high energy, hyper, delusional, grandeur, think they're like the president of the United States, always exaggerating.
We also have to pay attention to their diet as well, because they're always on the go. So we have to make sure that we give them certain food like that they can eat.
Yes, finger foods, right? That's really, really important. I'm really happy you mentioned that, because it's based on the same sorts of things, but it's like the opposite, right? Depressed, they might have somatic delusions where they believe people are giving them things or they're going to get sick from that. Whereas in mania, they might have delusions of grandeur. So they're going to be like, they believe that they're like the best in the whole world, and they're going to be jittery, and they're not going to really be focused on eating. I mean, technically, a depressed person can also not really be focused on eating, but this is because they're just so energized. They have so many things to do. You want to give them like finger food and chips just to make sure they eat something. And because they're also really competitive, they like to spend a lot of money. We want to set limits with them, and they like to wear outlandish clothing. So we want to watch that. And what someone mentioned, they like to do undressing or disrobing. So we want to make sure we cover them. So they might be our patient that we see running in the street, without clothes. And we also want to decrease stimuli because we don't want a lot of bright lights and stuff because they're already overly stimulated. Whereas with our depressed patients, right, we might want them to have like lights and things like that because they're not really getting out much, and it could help increase their mood. So it's just the opposite of what you would do for one, you would do for the other. But regardless, they're both at risk for suicide, so you have to do suicide assessments for both of them, like I said, if we have those indicated findings. But we also want to make sure that specifically with our manic patients, we watch out for violence, right? So we don't want to try to manage them alone or leave them alone. And we talked about all of the different sorts of interventions. I kind of rewrote them out here, where you want to decrease stimuli, decrease choices because they're depressed. They can't really make decisions on their own. Simple communication, small frequent meals, watching diet, things like that. But with manic, they want to set limits with them, decrease their stimuli, don't indulge in their bizarre behavior and things like that. So what does lethality mean? Or another way to think about it is what does lethal mean?
Something that would kill the patient?
Dangerous.
Yeah, so lethality is the likelihood of death to occur, right? If they said that was a lethal accident, it was a deadly accident or death was likely to occur. And what did we say that ambivalence was? It's these two opposing ideas where they want to live. Wait, say that. Sorry, I didn't see you come up. I saw it now. I didn't know who was speaking because I came up really quickly, but I think it was the idea that there's the two opposite ideas, and the idea that the person wants to live, but they also don't know how to live with their current situation. Does anybody else have anything to add?
Yeah.
Okay. So what about risk factors for suicide? What are risk factors for a suicidal patient? Is having a family history of suicide a risk factor?
I think so.
Yeah.
Mm-hmm. What about if they just had a recent loss, like they just lost someone?
Oh yeah. Or maybe they're not job loss.
Mm-hmm. What
Maybe getting a
about
divorce.
exactly right? If they lost their spouse. What about depression? Could depression be a risk factor for suicide?
Yeah.
Mhm. Yes.
Also, the sex of the person. Males are more lethal, but females make more attempts.
Yes.
And other things like taking alcohol and drugs, having previous attempts, no social supports. And what about your socioeconomic status, right? That could be a factor.
Yeah.
Yeah. And a history of psychiatric illness, right? If you have other mental health disorders, that might increase your risk for suicide. And we already spoke about this, but the first question in a suicide assessment is, are you thinking of harming yourself? What is your plan? And assessing lethality. If they said, like, you know, depending on the plan, we could figure out, like, how organized that plan really is. So if they just said I was going to hit myself in the head with a book versus someone going to jump off a bridge, we know one is more lethal than the other. But we already said put them on one-to-one, within arm's reach, a suicide contract, keeping 2 people in the room, liquid medication so they don't try to hoard pills. And yeah, what are some like verbal cues? Like what would be a direct thing that a patient can say that I'm like, oh my God, they might be thinking about hurting themselves?
I want to die.
Yeah, right. That's pretty direct, or I don't want to live anymore. What about like indirect ways of saying that I don't want to live anymore?
I can't go on like this, and I guess that's when you begin to ask them what they mean by that.
Exactly. And other things that we mentioned before, giving away possessions, changes in appearance.
Oh yeah.
Mm-hmm.
Especially something that they really, really love. And if you see they giving it away, that's a sign.
Exactly, right? So it's like, if they're trying to do these things, getting their affairs in order, changing their appearance, giving away, you said, prized possessions, we're like, we gotta really think about that. And also, loss of any kind, right? If they have some sort of loss that could increase the risk for suicide. If they lost their partner, who they've been together for like 60 years, they might be really upset. But okay. So I also remember she wrote down borderline personality disorder, and I remember that, if someone can correct me if I'm wrong, I remember that as being the person's very manipulative. And because of that, they really want attention, and they're willing to do anything. They're even willing to hurt themselves to get that person to be for themselves. So I think that's all we would need to know about, like, borderline personality disorder. We talked about interventions and things like that. And for people who are depressed we can give them antidepressants. What are examples of antidepressants? Well, we have the TCAs, the tricyclics, which are lethal in overdose. We have the monoxidase inhibitors. And what sorts of foods would we not want to give to someone who is on that?
I mean,
Okay, and what are examples of that?
Chocolate, wine,
yeah.
certain aged cheeses,
Mhm.
salami.
Mm-hmm. Yeah.
I think pepperoni too. I'm not sure.
Yes, pepperoni.
Pepperoni, right? Okay.
Yeah, pepperoni. All that stuff. I didn't get to write down, like I said, all the drugs, but I know like tryptolene is an example of a TCA. The MAOIs are like really weird, like they're like IS8Z, something like that. The SSRIs, I think an example is like sertraline or something like that. But we also know that with the SSRI, speaking of that, a big thing is sexual dysfunction. So we monitor that closely in our patients. I don't know about the NSRI, so I didn't get to search that up. Did anybody have anything to add for that?
I don't.
Yeah, I'm gonna have to search that out. Like I said, I didn't get through everything. I tried to add as much as I could into this, but I didn't have that much time. But okay, so then we have mood stabilizers. What is an example of a mood stabilizer? Is lithium a mood stabilizer?
I think so.
Because you give it to patients who are manic, right? So basically we look at blood levels between 0.6 and 1.2. We never want it over 1.5 because that means toxicity. And they're excreted through the kidneys. Well, lithium is excreted through the kidneys, which means that we want to monitor like sodium and potassium levels. And other ones that we can include to give to a manic patient could be potentially atypical antipsychotics. Why? Because remember, they can also have delusions of grandeur. And anytime a patient is psychotic, meaning they have hallucinations or delusions or both, we can give them antipsychotics. And we could potentially give them anticonvulsants like Tegretol, Depakote, or Lamitol. I didn't get to find generic names for that. But, yeah, those are some things for mood stabilizers. And any questions?
So far, so good.
Okay, so what about levels of anxiety? What's the best level of anxiety?
Mild.
Okay, and do we need any interventions for somebody who has mild anxiety? No, right? Because we need anxiety. We need some sort of anxiety every day. So it motivates us. What about moderate, or it's a little bit more than mild? What kind of interventions would you do if you were feeling a little anxious or nervous?
Exercise.
Okay.
Reduce coffee.
Okay. I like to journal.
Deep breath.
Deep breaths, yeah, I definitely breathing.
That's a good one.
Deep breath is really good. Journaling, I like to write things down. Music, right? So we definitely want to do things, like I said, love the deep breathing that we added in. Changing your mindset, like cognitive reframing, saying like it's going to be okay, like being positive, things like that. And they have decreased concentration. So they're not like, they can understand what's going on. They're just a little, like, I feel like it's like before an exam. It's a little bit more than mild. You're like a little nervous, but then you'll calm yourself down once the test starts, you know? But what about severe? What do we expect with that kind of patient who's in a severe level of anxiety? Do we expect them to be rational? What is a safety priority for these people? If they're in severe panicky levels and they're not thinking rationally, what should we worry about?
Suicide, violence.
Yes, exactly. So we want to never leave them alone because they're at risk for suicide and violence. And they also have selective attention, so they're like only able to focus on one thing out of maybe all the things you might have said. So talking with them might not be your best solution to help these patients. What about panic level?
Also have to monitor for violence and suicide. Also, we don't leave them alone. The safety, maybe one-to-one.
Anybody else have anything to add? They can also have psychosis, so they just don't know what's going on. So in that case, we could potentially give them an antipsychotic, right, to help them. But regardless, they could be having hallucinations or delusions because they're in such a high level of panic. And like we said, suicide and risk for violence for both severe and panic, so we want to have suicide precautions like within arm's reach and things like that. Other medications for anxiety include benzodiazepines. What's an example of a benzo?
Diazepam, which is Valium, Ativan, Xanax.
Yeah. So some of those things with those drugs is that Valium and Librium are used for alcohol detox, is what Professor wrote over here. We also should never use them with alcohol. They're also a high risk for dependence and addiction, right? So benzos can be highly abused, so we have to be very careful with that. And what's an example of a non-benzodiazepine?
Buspar.
And it's non-addicting, and it takes about 10 days to work. But there's also other anxiety disorders. Like I said, for whatever I didn't get to put the generic or the brand name for, you just might have to search that up because I didn't get to fully finish, but I tried to. But we also had different anxiety disorders that she said we should look at. So what should we do if a patient has a phobia? What do we do? Do we allow them to avoid their fear?
No.
No.
No?
Yeah.
Yes, because we don't want to force them to face their fears. So we allow them to avoid their phobias. They have avoidance. We don't interfere with that. What about OCD? What is something we don't want to do with those patients?
Oh yeah, it's true. So we don't want to interrupt their, that's true. We don't want to interrupt their whatever pattern, I guess. So like if they keep washing their hands like 10 times, allow them to wash their hands.
Yes.
Alicia, I thought that about phobias is confronting the phobias. Like, I'm afraid of flying. They said in order for me to overcome them is like confront it or like go to the airport, getting on a plane, I don't know. I thought that it would be confronting it rather than avoiding it.
It's weird, but it's like we can't force the patient to. So if there's like a bee in the room, right? You just get this patient and they're extremely scared of bees. You're not going to tell them go to the bee. You allow them to avoid it because that's going to relieve their anxiety. Because the ritualistic behaviors and the avoidance of phobias are their ways of relieving anxiety. As you did say though, like a way to help reduce phobias is to expose them to it, but that is not necessarily our role. We have to, like, if they want to, we could say, okay, we can get you interventions to do that. But if they're in the midst of having like a panic attack because of the phobia, because they can get up to panic levels. We just want to allow them to avoid it.
Right.
Yeah. I hope that helps. But I just wrote down 2 different phobias. I remember there was social phobia, which was fear of social situations or being like embarrassed. And then panic disorder with agoraphobia, which is like they're scared of like the crowded situations. So they have to sit near exit. Like they're scared of not being able to get out. So they sit near like exits or they go with the person somewhere. As we said with OCD, we never interrupted ritualistic behaviors. With PTSD, they're at risk for suicide. And then generalized anxiety disorders when they worry 24/7. And another form of OCD is hoarding disorder. For somatoform, we were kind of talking about that earlier. She just said kind of no physical symptoms. So when we think of somatoform disorders, what are we thinking of? Like, what is the patient saying like they have, or do they think they have something that they might not?
Yeah, they think they might have, like, for example, the patient might think, okay, they have cancer.
Yeah.
Yeah, and they might complain of like all these pains and stuff, or make these, oh, there's a lot of physical complaints that might relate to nothing or just be related to distress. And they might not have any medical conditions that actually relate to that. They usually don't. They just have these complaints. Also, dissociation. Does anybody remember what that term meant, like dissociating?
You're not in touch with yourself.
So nobody wants to say what dissociating is? Or I could say it. I don't mind.
Not in touch with themselves.
Oh, not in touch with themselves. Sorry, I didn't hear that. Yeah. Anything else to add with that?
Like for instance, if a person was raped, they don't want to confront that or even think about that post-traumatic stress, and they block it or they don't want to face it because it hurts too much to feel that or remember that traumatic event.
Yes. Okay. If no one else has anything to add, I'll move on to attention deficit and hypersensitivity disorder. Okay. So I know we like just learned about this too. So some things with this are that the 3 symptoms were inattention, hyperactivity, and impulsivity, where they act without thinking. And Dr. D said the diagnostic criteria was that it's usually diagnosed before 6, and it's usually in 2 settings. If it's for a child, it's the home or school, and if it's an adult, it's home or work. And then we started talking about the psychostimulants, which is interesting because she was saying like, oh, you give these to patients who are hyperactive. They kind of cause like you to be hyperactive, but they also somehow by doing that help manage the restlessness. So it is an interesting like counter, or what she calls is a paradoxical effect. And examples are like Ritalin and Concerta, especially for children. And she said that Concerta was the long-acting medication that you take 1 time a day, and a school nurse should know how to do that. And these are controlled substances. And nursing considerations for these that she wrote down were: do not give them after 6. They can cause insomnia. They can affect growth and development. So you want to keep a growth chart, monitor the blood pressure, and obtain blood work. And you also want to set limits with these patients, which makes sense, right? If they act without thinking, they might do something where that could be inappropriate. And they might also be just so hyperactive, they might not know, like, when to stop. So does anybody remember, like, the steps for setting limits?
I don't really, I think, like, so first you would let them know like the things that, like the rules. And then I think for the second part, you would like, let them know, hey, if you break the rules, this is what's going to happen. And then if they still break the rule, then you're going to have to, put it into action. Whatever that step was, that if you break the rule is what's going to happen, then you're going to have to put it into play. So if let's say, for example, if you say, okay, if you break the rules, I'm going to turn off your TV. And if they break the rules, then, okay, that's what I'm going to do. I'm going to turn off the TV. So this is how I remember it.
Oh, that's really good. I kind of think of it if you have kids or you have animals, so you tell your dog, you could do that, or you tell your kid, you could do that, and then you're like, no, we don't do that. And if you do it again, like you said, take away your TV or not let you do something. And then, as Dr. said, the most important thing is following through, because that also, I think, helps gain respect from the patient and you, and even if you have kids, right? Because if you tell them, hey, I'm going to shut off your TV, or you're not going to be able to do this, and you don't, they know the next time they could probably do it again, because it won't actually happen. So I think that's really important. And with adults with ADHD, she said the medications are typically like Adderall and Strattera. I didn't get the generic names for those, but they're also highly abused. They all are. Ritalin, Concerta, all of them. And the thing with controlled substances is that they all have a high risk for abuse. And yeah. And does anybody want to add anything? No. Okay. So with autism, that's something new that we learned about. I wrote down because she talked about slide 18, so I went back and I typed that slide in, and they were just saying that there's long-term outcomes for children if you have early interventions and identification and treatment, which makes sense. Screening tools for autism have been developed, but most are used in toddlers and infants. And I also got that screening for prodromal symptoms, which are prodromal, I think, means early. In infancy, some of the more debilitating features of the disorder might be mitigated with early intervention and treatment. The diagnosis is usually before 3 or at the age of 3, and common in men. They cannot connect with people or have relationships. She said it's usually obvious from birth. They have echolalia, which is what again?
Repeat.
Echoing? When they repeat.
Yes. And what symptom is that in schizophrenia? Is that positive or negative?
Positive, I think.
Sorry, I like to do that when I see something. I test. I do that with myself. That's why I do it. And then what is ecopraxia?
That one was the one when they follow what you do. Like if I lift my hands up, they're going to lift their hands up.
And is that a positive or a negative symptom of schizophrenia?
I think it was also positive.
Yeah, that's how I like to train myself. I like to repeat because I think it makes it easier if I can identify some things. But yeah, they also connect to objects and they're prone to self-injury. I don't think I have anything else to add. Yeah. And then we also started talking about oppositional defiant disorder, which she says like common in adolescence where everything is just like the opposite. So the dad says no and the kid's like yes, or vice versa. They're not really aggressive. They just kind of do the opposite of everything, like all the time. That's all I really have for that. I don't know if anybody else has anything to add on. I have this in my office. I didn't see that they want to do their own thing. Okay, and then there was conduct disorder, where she said the diagnostic was like ages 10 to 19, and 40% of them usually develop antisocial personality disorder. And with conduct disorder, since we're seeing this in the age population from 10 to 19, we see things like they're really aggressive, they might rape other children, animal cruelty, violence, no empathy for others, bullying, things like that. And antisocial personality disorder, you'll usually have conduct disorder as a result, like they seem to be correlated. And things that they have are impaired conscious. They don't know what's right and wrong. They can seem charming, like we were talking about Ted Bundy, how he was like this congressman and like everyone loved him, and then when he was going home, he was meeting women and killing them. So, yeah, I guess that also makes it very scary because they could be someone as charming as he apparently was, and they are not so charming. They break the law, they steal, no guilt or remorse, they don't learn from their past mistakes, they violate the rights of others, and they get what they want. And there's nothing that we can do to change their behavior. They're just the way that they are. Something else that she also put in her notes was that schizophrenia, depression, mania, bipolar, anxiety, you can get them in adulthood and you can get them when you're children. There's no like, oh, you have to get them at this point. And then for crisis, I didn't write down like everything from there, but I wrote down like some of the key things, which were that a crisis is any stressful event, and there's different types of crises. There's developmental, situational, adventitious. Developmental is like growth and development, so something happening in those stages. Situational crisis, like something that's going on right now, like maybe our situation is studying for midterms or writing a paper. Adventitious crisis is like a natural disaster, like a hurricane, a flood, terrorism, plane crashes, rape. And then two things can usually happen. They either develop new skills or they're unable to cope. The goal is to get them back to their pre-crisis functioning level. And the guy, what was his name, Kaplan, said that usually in 6 to 8 weeks it should resolve in one way or another. And I definitely forgot to write this down because I didn't see that there was another page. But looking at it, she said to only pay attention to these, which are the 3 balancing factors, which is the individual's perception of the event, the availability of support, so what is going on right now, who was there to help, number 2, and then how are you coping, or what do you have to cope? And yeah, is there anything anyone wants to add or something that I missed that they think I should add? Like I said, I didn't get all the generic drugs or all the drugs, especially for like the second generation antipsychotics. I gotta go back and do that, but everything else is pretty much here. So yeah. Would you all want like access to this typed version for you?
Yes, please. Thank you.
Okay, just ask me because I'm gonna forget who wants it. But yeah, so that's pretty much it. I think this was a good session. I'm gonna stop recording if I know how to do that.